Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of the Kidney Coach and Kaigenesis, a range of natural supplements designed to support those diagnosed with chronic kidney disease. I'm joined today by one of my favorite guests, the wonderful, the amazing Lindsey Zirker. Lindsey is a renal dietitian with a long history of working in dialysis. In fact, it wasn't until I was reading all your anemia course that you put together, Lindsey, that I realized just how long you'd worked in dialysis. I know you mentioned it, but yeah, that's really where you started out and really honed skills. That's one way to hone your skills. She now works for the Kidney Nutritional Institute as one of their head renal dietitians there, but she is a wealth of knowledge on all things hormones and minerals and vitamins and pathways and anemia and chronic kidney disease and autoimmune disease related to kidneys. So, Lindsey, welcome back. How are you?
Thank you. I'm well, and I'm excited to talk today about calcium.
Yeah, we had a little chat about it before we hit record. You and I share the same frustrations when it comes to calcium. So, let's just dive straight in. So, we'll get to our frustrations, I'm sure, as we get going. But calcium, what is it? How does it work? What are the major things as far as deficiencies that we need to know about? And then really quite specifically into kidney disease. And let's go from there.
All right. Yes, so calcium is definitely, I feel like, one of the minerals that we hear commonly about in kidney disease. And the big concern or the big focus on calcium is to make sure it doesn't get too high. That's the big focus. That's what the guidelines are focused on from KDIGO and from KDOKI. Um, and so that can lead to a lot of questions about diet because calcium's a mineral that is found in a lot of foods. Um, and calcium is really important. It does a lot of important things in the body. I think most people are familiar with calcium because of its role in bone health. Um, but it also, does stuff with teeth, and lots of other transport and biochemical pathways and stuff like that. Um, I think that one of the things that we want to make sure we talk about today is that calcium is important, but to support and help calcium, you can't actually just keep your eye on calcium. You have to be looking at other things. Um, and we'll kind of get more into why in a minute. But I think that's kind of one of the tricky things with calcium is that if you're trying to pay attention to it in kidney disease, by the time it's starting to behave strangely, there's already a whole host of problems going on. And so
Yeah.
makes it difficult.
Yeah, it really does. And like you say, the focus generally is on high calcium and it's linked to the parathyroid hormone and all those sort of things. But, before we hit record, we were talking about, and you and I have both seen this, people, especially on dialysis, with low calcium,
Yeah.
0.6, and nobody says anything. They're just like, okay, great. It's not high. And we're like, what? Like it is not.
Calcium's important. Yeah.
Yeah, so let's go through. So let's with calcium, we need to do both things. So let's first talk about deficiency. So if someone was deficient in calcium, um, talk to me about the labs and then talk to me about what sort of symptoms you might see in a calcium deficiency. Because I know people are thinking osteoporosis, but there are a whole pile of other symptoms that can
Oh,
come
yeah.
along in calcium deficient. So walk me through those.
Yeah, and it's tricky too because there's all kinds of different bone diseases going on in people who have kidney disease. So depending on how advanced it is, the labs may not be so reliable. So
Yeah.
we'll see if we can shed some light on that. But generally speaking, calcium's lower than 8.8 milligrams per deciliter since, we got different, units around. That's typically considered low
Mm.
for quote unquote regular people. And I feel like this is always something we need to remind ourselves as providers, is that people who have kidney disease do not have some magical system in place where they actually need more or less of certain nutrients. Their bodies well, I guess we should say less of certain nutrients, like for phosphorus. People who have kidney disease don't have lower phosphorus needs, and people who have kidney disease, they don't have lower calcium needs. We haven't had studies that show us that. Your body still needs those things. So the problem that gets run into and why the focus is on high is that they're concerned about higher levels causing negative cardiovascular outcomes, which is the top like complication, cause of death, and stuff for our kidney peeps. So um so yeah, they're looking at serum levels. But as we've talked about many times with minerals, serum levels are not very reliable. And
No.
calcium is definitely a poster child for this. It is so tightly regulated by hormones. And that's why by the time you see weird levels in the blood, that means the hormones have already lost their minds and, and they cannot handle it anymore.
Yeah, you're so true. And like iron's the same. Like those two minerals are so tightly controlled by the body because they are ones that need to stay in this really narrow
Yeah.
range. And when we're seeing either side, high or low, that's been going on for a long time. Like you say, the whole horse is bolted. Like we're out.
Yeah.
To put everything in is not just about reining in calcium. It's about reining in all it's like a whole bunch of Mustangs are out and
Hmm.
we got to get the whole field back in. So, all right. So symptom wise, you talk about cardiovascular. Are there any sort of really regular symptoms that people with kidney disease might experience if they were too low?
Sometimes high and low sign symptoms are the same. So
Mm-hmm.
again, tricky. So you can have with deficiency, you can have muscle cramps, spasms, muscle twitching. Um, but I feel like more with too high of calcium, it's more, why can't I think of the word? But like the the muscle cramp just goes like tight. Like you can't like unclench your fist. What is the word for that?
Yeah.
Why can't I think? So kind of similar, but a little different. But people can experience seizures, heart
Mm-hmm.
failure, but also brittle nails, dry skin, mood changes like irritability or depression. And then, yeah, we have some bone issues like osteoporosis or osteomalacia. But with toxicity, you can have some of those same symptoms. Um, and to add on to it, a lot of times you can, if it gets too high for too long, this isn't an acute calcium issue. It's the chronic high calcium issues. The calcium can get deposited in soft tissue. So that's
Mm.
something that we hear a lot about in kidney disease is the calcification of vessels and and organs and stuff.
Yeah, and even in cardiovascular disease, right? One of the things we check is a calcium score inside the arteries, which
Yeah.
is interesting, right? Because again, this whole calcium metabolism and pathways and how we have a calcium score checking inside the arteries for atherosclerotic, it's part of that, disease, and yet we
Yeah.
see deficiency and things like that. And so that comes back down to, and I'll let you elaborate on this, is like all the cofactors and the hormonal pathways and everything that keeps calcium in check, that we even need to be checking calcium scores inside blood vessels and everything else. So,
Yeah. More data is, I think, so much more helpful because it isn't just the presence of high calcium, like in the serum, that is causing these problems. It
mm,
is this dysfunction with calcium metabolism. Um, One of the things that I thought was interesting when I was checking into more things with calcium toxicity, you can have heart arrhythmias. But interestingly, if you have low calcium, it's harder to protect your heart from the potential of heart arrhythmias if you have high potassium.
mm,
So when people have higher potassium, that is the concern is that they can have a heart arrhythmia. But if there's adequate calcium, then those gated voltage channels, they work it out. The higher calcium levels will also like they can kind of stave off the arrhythmia that can occur with high potassium. But if you are low potassium and low calcium, what's going to happen? You have no
Mm.
built, like your body has built in different safeguards and you've got nothing there. So,
And that's fascinating down to people may not know is, those minerals play a big role. Calcium, potassium, and magnesium are the big three, play a huge role in exactly what you're talking about, voltage and channel gates and channel ion gates that move ions inside and outside of the cells for voltage. And that is controlled by those three. And those are the big ones that will fluctuate in kidney disease. And we just, you're changing our cell membrane voltage potential, like the on-flow effect of that. Huge,
yeah.
right? You want to say anything more about that? Because that's, my knowledge on that stuff, apart from those three and having those three really kept in check, is probably fairly a bit more limited than what you probably know about that.
I don't know. I feel like it's really hard to get a grasp on what's going on
Mm.
because we have medications that are pushing or pulling these minerals in different directions in different ways. Then we have supplements, and then we have diet, and where these are stored, and the muscle mass and acid and base balance. Like it's easy to see why things get super messy in kidney disease. And
Mm.
so I feel like just knowing that it is a mess is like the first step to acknowledging that it's not that simple. It's not that straightforward. We have to take a deeper look. Um, and I don't know. I just feel like we were kind of laughing about it earlier, but I was like, so boring when people aren't wondering, why is calcium doing this? Like, why can't they be cool and be more curious? And I feel like it's the mark of a good practitioner who's curious. Like people who
Mm.
know everything, then then they're going to miss stuff, right? Because no one knows everything. And then people who don't know anything and aren't curious, well, they're going to miss stuff because they're never going to figure anything out. And so I feel like if you're like, "Oh, is my doctor good? Are they helping me?" Are they curious? Are they trying to figure out why your labs and your symptoms aren't matching or things aren't going as expected? Like, don't be boring, be curious. And that's what you want from your providers. That's what I think. That's my motto.
It is.
Um,
It's great. We had a good laugh before we hit record because Lindsay originally said, "Why are people so boring? My God, I'd be curious." And I was brilliant. I said, without offending people, but and I think that's we were saying too. The more and more, I mean, I just think it's hilarious that we're writing like chapters for medical texts because I'm like, really, I don't feel like I don't know anything, but it's down to this curiosity piece, right? Like you and I have similar brains as well. We just love research and down the rabbit holes. But the more down the rabbit hole you go, you're just like, holy cow, like it's a mess down here. Like, number one, the human body is amazing about how it keeps everything
yes.
in check. And two, especially when we're talking about things like calcium, and, again, we had this discussion before we hit record, just when you're seeing calcium move and I'll get you to talk about this now, it's rolled to the parathyroid hormone, vitamin K, vitamin D. Like there are so many things that have shifted like an earthquake. It's like an earthquake comes and everything, all the mud gets shifted underneath it. And now it's just depending how everything is sliding into place. And whatever's going to go down the hill, is it going to be your kidney function? Is it going to be vascular? So many things can go out. Are we're hitting metabolic acidosis? I mean, I feel like in clinic, the first thing I do with all of my patients is if we've got a high anion gap, I'm not doing anything really until I've got them alkalized because of that role that it plays in mineral transports. Like if you're acidic, that's a great way to blow all your minerals completely out the window because they're spending so much time trying to protect these ion gates and then trying to alkalize everything. Like it's just crazy. So yeah, like these minerals, I know we've been doing a series on them, but they don't get enough attention, do they, about just how important they are just to keep in these like reference ranges and why it's so important that we look at them, but not isolate them, look at them as more.
Agreed.
We keep having a crossover. We keep talking about vitamin D and parathyroid hormone. We're talking about phosphorus and all those sort of things. So
Yeah.
talk to me, because most people are going to think about in kidney disease, most people are going to be aware of elevated kidney and the parathyroid hormone and hyperparathyroidism. Let's go down to what most people are going to have heard of, but why we think that's so limited in its reach as far as its relationship to kidney disease and calcium.
Yes. So kind of circling back to hormones run the show with how much calcium is in the blood, right? So parathyroid hormone is the mother calcium hormone. It is going to be responding to things. And that's why, um, if you're trying to figure out is something weird going on with calcium, you don't want to just look at calcium. You want to look at other hormones or nutrients that are having an impact on it. So the next step would be looking at parathyroid hormone because it's going to be monitoring the calcium levels in the blood. And if calcium levels get too low, then the parathyroid hormone is going to send out messages to the kidney and the bones. And it's going to say, kidney, we have not enough calcium in the blood. I need you to stop peeing it all out. I need you to send it back. And then it's also going to say, can you also tell vitamin D to go to the gut and go pick up some more calcium? So it's going to activate the vitamin D, send it to the gut, and get some more calcium absorption. Then it goes to the bone and is like, I don't really care that you made that nice new structure. You have to break it down and release it into the bloodstream because we need calcium, because calcium is important to do all of our stuff. And so it's really bossy like that, and it will be heard. So, so it does all those things, and those like are the main pathways that help keep calcium at like normal levels in the blood. But as kidney function goes down, notice how two of those main pathways rely on the kidney to do its thing. Only one of those pathways is left if the kidneys can't keep up, and that is breaking down the bone.
Mm.
And I feel like we've talked before about this. Maybe we haven't, but breaking down bone, I think everyone gets that. That's bad. But we don't think about what other things are stored in the bone that are going to get released if you're constantly breaking that down. Heavy metals are going to get released, and that's going to cause its own shenanigans in the body.
Mm.
Um, so that's kind of keeping the calcium in check. And some people are like, well, my calcium is high and my PTH is high. So, yep, congratulations. You moved into another stage of a bone disease where the body's like receptors, they're all off. People aren't paying attention anymore. And yeah, it gets complicated. But one of the other things like vitamin D. That's part of the calcium regulation pathway. So because the body has other vitamin D activation um, in different places than just the kidney, then making sure people have adequate vitamin D on board, that helps to better regulate PTH, regardless of what's going on with calcium.
Mm.
So it's really helpful. And I think when we talked about phosphorus, we talked about clotho and FGF23. So
Yeah.
those are all still involved, and no one is testing FGF23. Actually, I had one patient have it tested, and I was like, "This is so weird. I don't even know what to do with this."
Was it high or low out of interest for
It
kidney
was
disease?
normal, and I was
Oh,
like,
wow.
"Good. We have time to do stuff. Make sure your vitamin
Wow.
D is good." That's what I said, because no one knows really what to do with it. We're still learning so much about it. But the thing that is clear is if you have early kidney disease going on and you want to prevent weird stuff from happening to your hormones, then make sure you've got nice vitamin D levels. Don't let
Yeah,
those levels get too low.
no.
And
And yes, sorry, pick up.
I was just going to say, sometimes there's a concern that, vitamin D is going to cause high calcium.
Mm.
And so there are different types of vitamin D that kidney patients get. They have vitamin D, uh, like D2 or D3, or they have like calcitriol, which
Mm.
is an active vitamin D. Now, we know vitamin D helps the body absorb calcium, but I feel like in the vast majority of studies I've looked at, giving vitamin D to kidney patients does not cause hypercalcemia. It's not
Mm.
going to cause the calcium to go too wild. Giving calcitriol, the active vitamin D to patients, that can cause hypercalcemia very easily. So that needs to be monitored closely. And that's why when you're trying to figure out what's going on with calcium, you want to look at labs of calcium and phosphorus and PTH and vitamin D. And you want to look at trends of those. And the guidelines, I was so proud of them when they put that in there that you can't make decisions about medication adjustments with just a calcium level or just a PTH level or even just one draw of all of them together. You need to be
Yeah,
looking at trends because they're going to change a lot. And if you want to see what's going on, you have to look at multiple draws of all those labs together.
100%. And now talk to me about vitamin K, because we haven't even
Yes.
mentioned K and his role with
Oh,
calcium.
yeah. So, vitamin K. A lot of times people think about vitamin K and they think, oh, I can't eat any green things because blood clots. That's what they think. If they even got that diet education in the first place, let's be honest. So, I actually wrote an article I just remembered about vitamin K and kidney disease. I want to find it so I can reference it real fast. But there's two types of vitamin K. We have vitamin K1 and vitamin K2. So, vitamin K1 is our green leafy vegetables, and yeah, plays a big role with blood clotting. Um, and then you have vitamin K2, um, and that one is the one that is going to be playing a role in bone health. And one of the big things that it does is it helps incorporate all those lovely little nutrients and things into the bone matrix. And so there hasn't been tons of research done on this to say, like, oh, people who have low vitamin K and they have high calcium. That's because there's not enough vitamin K to like incorporate calcium into the bone matrix. Like it's more complicated than that. But what they have found is that especially people who are on blood thinners, that when they administered vitamin K2 and they had dialysis access, those people had less vascular calcification of their dialysis access than people who didn't get the vitamin K who are also on warfarin.
Interesting.
And I felt like for myself, like when I was working in dialysis, like the doctors were always saying, like, you protect your access with your life. This is
Mm.
your lifeline. It is a big deal if it doesn't work or it malfunctions. And yet, no one wants to dig deeper into how vitamin K can help preserve that for acting longer. I feel like
Mm.
that's weird. People are boring. They need to be curious.
Totally agree. And especially when your access like that, you can save your life in a last minute sort of thing of,
Yeah.
and talk to me about the role of vitamin K2 and its relationship to our gut microbiome, because I find, as
Yes.
naturopaths, we always come back to everything, disease starts in the gut. And I always do think it's a little bit more complicated than that. But
Yeah.
K2 and gut and microbiome, talk to me about that link.
Yeah. So the friendly bacteria in the gut, they produce different vitamins. So there's some bacteria that produce different B vitamins, and they also can, some of the friendly gut bacteria produce vitamin K, K2. And so when we have our CKD friends who have dysbiosis, there's a really high likelihood that they're having less friendly bacteria who can produce that vitamin K for them. And from foods, a lot of times vitamin K2 is coming from dairy, like fermented cheeses and stuff like that. And that is often in traditional kidney diets restricted because of potassium and phosphorus. And so they kind of get hit double with the dysbiosis and the reduction if they're following or they've been recommended a traditional renal diet, which is no longer evidence-based. So, um,
Okay.
just sliding that in there. And so that makes it extra difficult. Also, some research is showing that uremia is a big deal for a lot of nutrients. Um, and there's reduced vitamin K cycle enzyme activity. And so, and it actually reduces like a lot of different transports and stuff like that. So uremia does more than just cause people to feel malaise and nauseated and awful and have bad labs. Like it's really messing with a lot of different systems in the
Yeah.
body, and vitamin K is included in there. Um, but I'm looking at my article now. Um, Ooh, this is one. So vascular calcification has is a big deal because they find it in 79% of non-dialysis CKD patients,
Wow.
and coronary artery calcification in as many as 88% of patients older than 20 who are on hemodialysis.
Wow. That's a massive percentage.
And that's why everyone is kind of freaked out about calcium-based binders and making sure calcium levels don't get too high, but they kind of miss the picture. Like, well, why aren't the hormones keeping the calcium, you know, like PTH is no longer like in hemodialysis patients, PTH does get filtered out. And so PTH is still high. Why is this a feature of secondary hyperparathyroidism? Like, what
Mhm.
else are we missing about calcium metabolism? And I think, not looking at vitamin K, not looking at vitamin D and phosphorus in those roles is a problem because they've been looking at just vitamin K status. So it's not causation. They're like, people who have really poor vitamin K status, they have an increased risk of calcification. And um, it's really common they found vitamin K deficiency is really a frequent issue when they have looked at it. Now, how do they assess it? Everyone's always confused. How do we assess vitamin K? But if
Mm.
they're just looking at blood levels of vitamin K and they're like low blood levels and more calcification, it's something that warrants further um, investigations.
It's quite
Um,
crazy that we like worried about osteoporosis, and yet our bodies and kidney disease seems to just like, who cares about a bit of calcium in the bones or high levels? We're just going to chuck it all into the blood vessels instead. Like, then the curiosity about, okay, the body's so smart. Why are we laying calcium into the vascular? Like, being a really smart body, and I don't know the answer to this, what would be the body's thought process, for want of a better word, to migrate calcium into the vasculature? Is that trying to set up a matrix of some description because we've got so much inflammation and damage in there that it's an offset to that, or is it like a part of the alkalizing carbon dioxide offset that we see is systemic metabolic acidosis? Like, is that trying to, I don't know, but I find it really fascinating that we're just going to chuck our calcium into the vascular system and cause fibrotic sort of changes. And yeah, like I find that so fascinating. I need to know more about that.
yeah, from when I wrote this article, they were like, maybe we have a few theories that when vitamin K is low, there's reduced production of matrix GLA protein,
Mhm.
and this is typically inhibits calcification. And so without the vitamin K to inhibit it, boom, there it goes. So that's kind of the prevailing theory as to why. And when we think too about like what all needs to be included in the bone matrix, like, yeah, calcium's there for bone strength and structure, that hydroxyapatite piece,
Mhm.
and phosphorus is there for that as well. But magnesium, it plays a role with hydroxyapatite, but also PTH secretion, osteoblast proliferation. You need magnesium to activate vitamin D. And then
Mhm.
zinc, we've talked about how that is like messed up. Like people are just peeing that out like crazy. Zinc promotes the formation of osteoblasts. It synthesizes the
Mhm.
collagen matrix. It helps with bone mineralization. Potassium reduces the acid load and prevents calcium depletion from bones. And fluoride stimulates osteoblast proliferation and mineral deposition in bone. And so I just think with fluoride in the water and then low levels or high levels of some of these other nutrients, like the body is just like, I am just doing my best here. And it's trying to say something like, oh, do you need to know that there's a problem? Here, let me shove some more calcium in the blood vessels. Like, I just feel like it's, it doesn't have a typewriter. It can't tell us in exact words what's going on. So
Mm,
we have to think, we know calcium metabolism is messed up in kidney disease. So how does the body try and tell us this? With PTH, with vitamin D, um, with, these other minerals, like we know that it needs friends, otherwise it's going to be depressed and it's going to do weird stuff. So
mm.
make sure you've got enough magnesium, make sure you've got enough zinc. Um, so I don't know. I just think, yeah, we want to make sure it's not too high, but not too low. Give it the rest of its friends so it can do its job.
All right. Yes. So interesting. So people with low, let's say they've done their labs and they're low calcium. And of course, I have to say again, we've talked about everything about K and everything that needs to go with it, but forms of calcium. Do you have a form as far as the supplementation goes that you prefer over others?
So kind of
Or do
depends
you prefer,
sometimes on other things going on. Like typically the best absorbed form is going to be like a calcium gluconate or citrate salts.
mm,
And especially if people are kind of acidotic, calcium citrate kind of makes sense.
yeah,
Um, but we know there's a lot of different phosphorus binders out there, like calcium acetate, calcium carbonate.
yeah.
Not the best, really. Um, but I think that, there's a lot of factors. Calcium citrate isn't as dependent on stomach acid. And so, especially for our people who have lower stomach acid, I mean, that's a whole other thing. Do you really want to be giving huge doses of calcium to people who have low stomach acid? Like, got a few things to fix there, probably. But
Mm-hmm.
at least they can absorb that. And there seem to be fewer side effects with calcium citrate.
Yeah, that's
But
my.
I feel like there's different forms that can be good. Do you have a favorite form that you like to
No,
use?
for kidney disease, I'd go for citrate as well.
Hmm.
That's absolutely my favorite form to go for. Plus, as we've mentioned, all of calcium's friends. Village takes a village to re-regulate calcium. He's not going to do it by himself. So D, K,
Yes.
boron, zinc. All those guys. Magnesium.
One of the other things that I just remembered about calcium, super important. So oxalates and calcium, they are connected, right?
Mm,
So kidney stones, people get concerned about like oxalates. So calcium is really great to help bind oxalates so people don't absorb as much. So if you have a history of kidney stones, having adequate calcium is important. But one of the other tricky things is that if you've had your gallbladder removed, if you had
mm,
like
mm.
bypass surgery, or if you have low stomach acid and it's not triggering the release of your other digestive enzymes, so you don't digest fat well, the fat is kind of going to gum up that calcium and is going to make it so that you cannot block that oxalate absorption. And
Yeah.
so fat malabsorption can be a big problem. I actually had two patients on dialysis because they had a gastric bypass and they didn't either remember or they didn't get good diet education about the importance of taking their calcium. And so they
Wow.
had oxalate damage to their kidneys.
Interesting.
Mm,
Yeah, well, I feel like that's not something that goes in the brochure with gastric bypass, personally.
I know. Well, that's why they were there.
Mm,
So, it's one of the things you don't really think about, but if you have poor fat digestion, you're probably not absorbing calcium well because it's getting
mm.
blocked and you're absorbing more oxalates. And so if suddenly you're like, wow, I was fine till I had my gallbladder out and now I also have kidney stones. Well,
That'd be right.
that's probably a big part of it.
I'm glad you went back and added that in. That's a really, really important piece there. It's funny, I've got a
Yeah.
patient like that I saw for the first time last week. So interesting. And
Yeah.
food. What are your favorite food sources for calcium?
Well, dairy is the popular one because obviously lots of dairy foods are delicious. No one's going to be depressed about having to eat more dairy. Um, but sometimes, can be a challenge if you're trying to watch other nutrients. But it is pretty well absorbed from dairy. But if that's not working because it's adding too much protein or whatever, fortified plant products can be a good source of calcium. And to be honest, I feel like for my lower protein, plant focused patients, getting enough calcium is tough.
Yeah,
And it is something that, again, because everyone's so focused on, it's too high, then we'll worry about it. But calcium is one of those alkalizing minerals, just like potassium and magnesium. If
Mhm.
you want to be alkaline, you need it. So, plant fortified products, so like plant milks or yogurts, those are good. But again, I do find this challenging because a lot of times if they're fortifying it with calcium, there's phosphorus additives in there too.
Yes,
And so
exactly.
so that's where you have to be like, ah, so how much phosphorus are they really getting from their diet? And if they are like eating more whole food, their phosphorus intake is also usually fairly low. And so
Mm.
for myself, I'm like, if that plant milk has, half of your day's calcium in it, but it also has phosphorus additive and your phosphorus additive intake is low, drink the milk. Like,
Yeah,
because there isn't any diet that is going to be beneficial if you're malnourished following it. So
very.
sometimes, you know, that's just, you got to work with the food sources that you have, right? So
Mhm.
yeah, I've got to take some lumps there. But other sources that are really high, surprisingly, collard greens. So obviously there's going to be some oxalates in there that are going to make it not as available for absorption, but it's still really high compared to other like spinach or other greens.
Mhm.
So, and then tofu also could
Yep.
have a decent amount of calcium. We're still working with oxalates in there, but you know, you still get some. So those are kind of my top four things that I look at to say, can we, boost up your calcium with one of these things? And then if not, then, we get more creative, but I don't
Yeah.
know.
Yeah. I love sesame seeds because you get really high absorption from them. And then of course fish with bones in it, all
Oh,
sorts of
yes. Yeah. That's a good one too. Those are good
sardines and mackerel,
additions.
things like that. Yeah.
Yeah.
Okay, what else do we need to say about calcium, Lindsay? We've talked about our deficiency, our high, our D, our K, our foods. What else have we not said about our friend calcium?
Do. So one of the man, I can't remember this reference if it was a study or a guideline, but elemental calcium supplementation of less than 1,000 milligrams daily is not associated with increased risk of vascular calcification. So I feel like that goes to, hey, you need calcium, so keep it under 1,000 milligrams. And like that is probably going to reduce your risk. But like we said, make sure you have all those other minerals together. Um,
Yeah,
and there's always exceptions. People have other unique things going on with their body. Um, but you want to make sure that you're looking at all of those things um, to to make sure you're seeing the as full of a picture as you can about calcium.
yeah, really good point. Anything else to add before we wrap up, Mr. Calcium?
I think we've covered a lot of good things. There's probably other things we could add. Oh, maybe real fast. So, because high calcium is a big focus, one of the things that I remember I was really happy I found early on in dialysis was the mnemonic of chimpanzees for causes of high calcium.
Mm,
And
yeah.
so Yeah, so that was kind of like my way to kind of try and assess like what's going on. We got, late stage kidney disease on dialysis, but I've ruled out all the simple stuff. So we have C for calcium supplementation, H for hereditary factors, hypophosphatemia, heartburn because of people taking Rolaids or Tums.
Yes.
I, am I going to say this word wrong? Iatrogenic or immobilization. M for multiple myeloma, milk alkali syndrome. So people having high calcium, metabolic acidosis, or kidney
Mhm.
injury. Medications like lithium
Mhm.
hydrochlorothiazide. P for parathyroid hyperplasia or adenoma. A for alcohol or adynamic bone disease.
Mhm.
N for neoplasm. Z for Zollinger-Ellison syndrome. Never had that with anybody.
No, me
Um,
neither. Fancy.
E for excessive vitamin D or A intake. E for extraskeletal calcification. And S for sarcoidosis, severe dehydration, or late stage secondary hyperparathyroidism.
Oh,
So,
yes, remember Mr. Chimpanzees.
yeah. So if you're trying to figure out the chimpanzees is a nice little mnemonic to roll out the common and uncommon causes for high calcium.
I love it. Learn something new every day. Thanks, Lindsay.
Yeah. Yeah.
All right. So if you're someone out there diagnosed with chronic kidney disease and you need a curious healthcare practitioner who cares to dig into why things might be the way they are, you can contact Lindsay and the team at Kidney Nutritional Institute. So they're kidneynutritionalinstitute.org, kni.org. I'll put their links to there below because they're in the US. They can work with anyone with insurance in the US via telehealth. And also outside the US, I know Lindsay's got a couple of my patients that she looks after when I can't take on high loads, which is fabulous. Thank you so much. If you want to know more about what we do, please head to www.kidneycoach.com. You'll also find us on Facebook and Instagram under Kidney Coach as well. Make sure you hit subscribe and like. That way you'll be notified anytime we put out more content. If you have any comments or if you've got any stories of calcium, please put them in below and I'll be sure to get back to you. Thank you for being part of our community, Lindsay. Thank you as always for your amazing knowledge and sharing it with the community. I am always eternally grateful.
Thanks, Fiona. Always happy to be here.
Thanks, everybody. We'll look forward to seeing you next time. Bye.